So it's interesting, you talk about out of the system in the ACO model, but at least in the Medicare shared savings model, there's no obligation by the patient to stay within the system, and in fact, many patients don't even know that they are within the system, right? Is that part of the problem? The notion that take an ACO type arrangement where patients are attributed, but ultimately still seek care through the same fee-for-service channels or mechanisms that they have historically in the Medicare program.
So while the patient may not be aware of this, I can tell you that a lot of people who are in ACO programs are trying to direct their patients to their own organization. So maybe it's a good, I'd hate to say this, but maybe it's a good thing the patients don't know that they are being directed to other kinds of providers based on the ACO incentives. But going to your other question, I think one key issue generally with the ACO movement is how do we get the patients engaged? Because this is happening behind their back. They don't know this is happening. And I think there is some role, and we're seeing that with some of the newer CMS proposals related to ACOs, where patients are now signing up, designating who their provider is. And I think in general, that's a good idea.
Right. So,
and I would just add, in reaction to a statement that Francois made a minute ago, I agree with you completely that when you take the sickest of the sick, those who are the largest consumers of the healthcare dollar, coordination is the most important for them. But so is everything else we're talking about most important for them. Because, you have 5% of the population consuming about 50% of the resources. But I would also posit this, that even those people who don't use a lot of services, I think the coordination, it improves quality, and I think it also reduces redundancy. That same person who might get a chest x-ray in one place and an EKG somewhere else, ultimately there is a possibility of redundant tests because it doesn't all go into a central system. That's a concern of mine. Am I alone in that?
Well, I think a lot of people would argue that health information technology should help, at least in that regard. But I hear it, chuckle. The federal government has spent an inordinate amount of money on sort of HIT through the HITECH Act. I think critics would say, this concept of meaningful use has been anything but meaningful to this point in terms of how HIT is being used. So, thoughts on that? Care coordination is important, but if all the investment we've made in health information technology isn't sort of moving us in that direction, what else is it going to take?
Boy, there's the outlay of resources toward HIT. It's just been enormous. It's one of the main complaints of physicians and hospital systems, the dollar amounts they've put into electronic medical records. And part of the idea is that it all gets coordinated, it gets centralized. You might have a regional health information organization where everything comes together, and theoretically it's supposed to reduce redundancy, it's supposed to coordinate all that, and empirically it makes so much sense. But so far we're having a hard time really proving the ROI is there. Francois, I don't know what your experience, is it that we're expecting those results too soon? Maybe they'll be coming eventually.
No, I think I'm going to pick up on Ateev's theme because the push towards having massively deployed electronic medical records came at the same time as the strong signal from the federal government around accountable care organizations. And those organizations who are trying to increase the amount of wallet share that they're getting for every Medicare penny that is assigned to them or attributed to them have found that deployment of the single electronic medical record system into their environment actually helps them to do that. So it's become a weapon around consolidation as opposed to a weapon around interoperability. And when you speak with a lot of those provider organizations, they have no intention of making their EMR system fully interoperable anytime soon unless there's a federal mandate to do that. So it's unfortunate that these two efforts, which I think separately were born from good intentions happen to converge and coincide in time in a relatively nefarious way. And the only option that we've got left, I think, is federal intervention, in particular with some of the larger EMR systems, to mandate semantic interoperability of EMRs. It would solve a huge number of problems, and it's, I think, if you talk to some of the past heads of the Office of the National Coordinator, they'll readily admit that they failed on that point. I mean, they dropped the ball on semantic interoperability. They just let the system evolve as is, and it's been used as a weapon to consolidate care.
Emphasize that point clinically. You know, I have a patient. I'm in the hospital taking care of a patient who might have a particular obscure problem. It's complicated care. Lots of different doctors have taken care of the patient. Even though there might be a doctor in the next health system over, I'm loath to send that patient to that doctor because it is critical for that subset of that population that all the doctors have access to electronic health records.
Yep.
So even though for that particular condition they could get better quality care at a doctor outside the system, because of the way the health system is set up, I'm not going to do it because it's bad for the patient overall.
Exactly.
And I think that's a real example of that use of, it could be used as a weapon to try to keep people internal.